Hello and welcome to Triage, rapid legal lessons for busy healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
And welcome back to Triage. My name is Steve Pine. I'm a partner in the RTP office. And today we are recording this episode at the end of April 2020 in the midst of what's been a healthcare regulatory structure turned rather upside down by COVID-19. And so for this episode, we're going to focus on a particular slice of that COVID-19 impact, which is what we've been seeing so far in terms of population health and value-based payment models that have been impacted by the COVID-19 crisis. And joining me today to share their insights on this issue are two of my colleague experts on issues of clinical integration and population health, Limo Cherian, a partner in our Chicago office, and Carla Dewberry, a partner in our Seattle office. Welcome to both of you. Thank you for joining, and hope you are both continuing to do well and stay safe.
Thanks, Steve. Good to be here. Again, this is one portion of obviously a larger issue across the healthcare spectrum, but I'm certainly wanting to talk about certain aspects, particularly related to ACOs.
Thanks, Steve. I'm happy to be here also. Look forward to speaking with you all.
One place to start the conversation is looking at a few areas where we have gotten guidance from CMS in terms of how COVID-19 will be addressed in the context of value-based models. And so I'll start talking a little bit about the merit-based incentive payment system, or MIPS, and what guidance we've gotten both in terms of reporting on data for 2019, as well as what impacts we might see for reporting and payment adjustments in 2020 and beyond. So for 2019 reporting, we've seen that CMS has triggered the extreme and uncontrollable events policy as it relates to the COVID-19 crisis, which means that clinicians and groups have an extended deadline to submit an application to certify that due to extreme and uncontrollable events, they were not able to provide all of the data necessary to be scored under MIPS and can therefore accordingly get a neutral payment adjustment under MIPS for the 2019 performance year. Now, again, we're recording this at the end of April. This will probably be released in May. So by the time you're listening to this, unless we've gotten additional extensions, that extended deadline to certify as to extreme and uncontrollable events will have passed. That went through April 30th, unless it has been extended. And so if you're listening to this and you weren't aware of this or haven't taken advantage of this opportunity, now would be the time to reach out to CMS and your QPP contacts to see what can be done. But the way that that will work for 2019 is if you are an individual and you have not reported any data for 2019, the extreme and uncontrollable policy will automatically be triggered such that you will have a neutral or zero payment adjustment, neither up nor down, for 2019. Groups, if you submitted some data, then you will still be scored on that data unless you have submitted an application subsequent to submitting that data, asking to take advantage and certifying that you need to take advantage of the extreme and uncontrollable policy. If you have done that, then as a group, you will be zeroed out and receive a neutral payment adjustment as opposed to an up or down adjustment.
Steve, based on what you said, do we have any insight as to whether a group could ask for that extension afterwards, or is that something they would have had to do? Do we have any guidance on that?
We don't have guidance on that yet. And I would say for a group that's in that situation, the sooner is certainly going to be the better to try and get that conversation and that advocacy in place with CMS if you were in fact impacted by COVID-19 in a manner that made it impossible for you to report data. So one additional aspect of this that I thought was interesting is that for groups that were able to report 2019 data and had positive data, they may actually see less of an upside than they otherwise would have because this program is budget neutral and because a number of folks are going to be taking advantage of this extreme and uncontrollable policy. There'll be less folks getting downside payment adjustments, and thus there will be a smaller pool available to folks that would otherwise have gotten an upside. So if you were expecting an upside, you might see that upside be less than what you were initially calculating. Now, in terms of 2020 and looking forward, because obviously beyond the reporting issues for 2019, this is obviously going to have a very practical impact in terms of cost impacts and quality impacts going forward. We don't have a lot of guidance yet from CMS other than they have acknowledged that they expect this to have impacts. They're monitoring that and they're expecting to issue guidance in the future. What we have seen, which is again pretty limited, is that there will be a new measure under the improvement activities where individuals and groups can report that they have participated in clinical trials associated with COVID-19 and provided that they meet all of the criteria, can use that participation to score 50% of their improvement activity under that aspect of MIPS. But again, that's all we have so far as future impacts 2020 and beyond. So that's an overview of MIPS within the Quality Payment Program. But in other value-based programs, what we've seen are really some dramatic changes to the Medicare Shared Savings Program that have just been released as of the recording of this triage. And so, Limo, let me turn it over to you to sort of give a broad overview of what we're seeing coming out of Medicare Shared Savings Program changes.
Well, Steve, there's actually some pretty significant changes. I mean, the most fundamental one, probably the one that requires understanding quickly, is that CMS has indicated that they're not going to have a cycle starting on January 2021. So there's no application that's going to be permitted for that start date. No new starts. Anyone who's planning on applying won't be able to do that for a January 2021 start. They did also release information with respect to entities, to ACOs that were renewing, whose participation agreements particularly were set to expire as of December 31st of 2020. Those ACOs, those renewing ACOs, are going to be allowed to extend their participation for a fourth performance year. That basically is a voluntary election. They don't have to make that election, and they're going to provide guidance as to how to make the election. If you don't make the election, then your agreement does expire on December 31st. 2020. If you do make the election to extend for that fourth performance year, there's a couple things to specifically think through. First, that ACO's existing historical benchmark prior to this year, because the benchmark is set by each year, would actually continue. So 2020 would not count as part of that benchmark going forward, because normally the benchmark is based on the most recent 3 years. They're going to exclude 2020. And then one of the other things in terms of if an ACO is going to renew or is going to elect for that fourth year, they should probably be looking at their participation agreements to make sure they don't need to actually affirmatively extend those. One other aspect that was part of this with respect to specifically the application cycle is that CMS has also announced that they're effectively freezing the glide path to risk for a year. Generally, for ACOs in the basic track, you progress year by year through this transition to higher risk. And so what CMS has announced is that they're basically going to freeze that for a year. So if you are in the basic track and you're supposed to move from level B to level C in 2021, you won't move to level C automatically. You can elect to do so, but you won't move automatically. The only thing to keep in mind about that is that in 2022, that ACO will go back to the place that they would have been. So as an example, an ACO that is currently at level B, which would have gone to level C in 2021, in 2022 is going to go to level D directly from B. So they will have skipped C and go straight to D. It's sort of confusing, but basically the idea is a one-year pause.
That makes sense. So if you're upside only right now, maybe you get an additional year of upside only, but then you're going to jump 2 levels to a higher risk sharing.
Exactly. And I also wanted to go back to talk to you to talk about some of the areas with respect to the quality payment program, particularly related to MSSP. You had mentioned earlier that the MIPS reporting deadline had been extended to April 30th. That reporting deadline extension also applied to MSSP. So any ACOs would have had to be reported by then. But there are a couple things that CMS had announced with respect to the quality program. The current policy is that the ACO is scored at the higher of the mean of the quality scores, or they're reported. That's what they're doing for 2019. They have not indicated what they're going to do for 2020. They're considering whether to extend that policy for 2020 as well in terms of the quality program. I want to highlight a couple things related to changes in terms of financial reconciliation for ACOs. First of all, none of these apply to 2019, program year 2019, because these are COVID related. And because the public health emergency didn't start until 2020, none of the financial reconciliation measures that we're going to talk about apply to program year 2019. But for 2020, CMS has announced a couple of things. First of all, they're going to reduce the amount of an ACO shared losses by an amount determined by multiplying shared losses across the total months that are affected by the extreme and non-controllable circumstances of the public health emergency. So because that applies to 100% of the counties in the country, it's going to apply for the entire duration of the public health emergency. Originally, CMS had indicated that was starting in March, but they went back and looked and realized that's actually January. So to the extent that that public health emergency extends, for instance, through the entire year, it could be that the shared losses would actually be reduced proportionally for the entire year. Again, because the idea is that the shared losses are potentially risky given what's going on with the public health emergency. One other thing that CMS is doing is removing Part A and Part B payments for episodes of care for COVID-19 treatment from program expenditure and revenue calculations. Basically, what they're trying to do is remove the impact of those expensive treatments from both the revenue and expenditure calculations for the purposes of financial reconciliation. That would assist ACOs in terms of their reconciliation.
And I guess smooth it out as between health systems significantly impacted by COVID-19 versus health systems with minimal impact from COVID-19.
That's exactly right. It'll basically level set across those different ACOs. CMS has also indicated that they are going to adjust the benchmark to remove COVID-19 expenditures. So that will help on a going forward basis as well, not just for program year 2020, but therefore not penalizing people in moving forward in terms of benchmark. There are a few other changes that CMS has announced. You may remember that there's been a lot of expansion of telehealth in the context of COVID-19 payment telehealth. CMS has basically indicated that they are now going to use telehealth codes for beneficiary assignment. The rule lists the specific codes that they're going to be using, but because so much primary care was delivered through telehealth during this period, they're going to be using those codes in order to do beneficiary assignment. See, the last part of the rule that came out specifically relates to Track 1 Plus. What CMS is basically trying to do here is saying that to the extent that there are rules that are promulgated for Track 1 or for Track 2 or Enhanced Track that would apply to Track 1 Plus, by rule, they're going to apply them to Track 1 Plus. So effectively what they're saying is because Track 1 Plus wasn't created in the same manner that the other tracks were, they're just trying to put them in the same position, those ACOs in the same position as they would have been if without the specific treatment that Track 1 Plus had to get. Not significant. It's going to really be the same thing for Track 1 Plus as for the others.
Got it. So if you're in Track 1 Plus, these rule changes would apply to you, I guess, the way you would expect.
Exactly.
Great. Well, thanks so much, Limo. Really appreciate that insight. And so, Carla, I wanted to bring you in the conversation here as well. We've been talking about what the federal government is proposing to do for these value-based programs. But of course, providers have a number of commercial contracts with insurers that contain value-based components through clinically integrated networks. What are we seeing in the commercial context as it relates to COVID-19 impacts on these value-based programs?
These kinds of contracts are becoming more customary in the commercial space. They often provide for upside risk and downside risks. So with upside risk, you're hoping to share in savings. And with downside risks, you're accepting the responsibility for covering certain losses. Currently, because of the services that are being provided or not being provided due to actions by certain states that have limited the services that can be provided in a hospital, for example, have required social distancing at the clinic level, you're seeing that providers are not providing services in accordance with their expectations they had at the time they entered into those contracts. So those contracts usually are heavily negotiated based on significant data that's shared between the insurance company and the provider group, so that both sides can understand the risks they're taking. Those risks now are significantly different than their understanding of the risks at the time the contracts were negotiated. So I think we're hoping that local insurance commissioners will address some of the equities with respect to the funding mechanisms that were incorporated in those contracts. The other thing I think that we're noting is that there's expectation that there will be an upsurge in behavioral health and substance use disorder care that will be required by a population. I think all of us are acknowledging that staying at home, losing your job, has created certain unexpected anxiety, and that anxiety may make itself known through the need for additional behavioral health services. I received a graph the other day that indicates that, at least in Washington, that by June, we should expect people will be acting out more. By September, we should expect more depression and suicide. In December, when we get to the holidays, there'll be exacerbated behavioral health issues. And then we're all afraid of what will happen if there's a resurgence of the virus and how that will throw, once again, all of our expectations offline, keeping in mind that commercial ACOs went into this period with financial assumptions in place that underscore the terms of the contracts they agreed to. Those assumptions are no longer in step with reality.
Carla, I completely echo that sentiment. I mean, when parties are negotiating these shared savings and shared loss agreements, they're looking at benchmarks, and then they're forecasting medical expense and medical loss ratios, and then working on an assumption based on the trend. And the issue right now is going to be for all of these contracts, all of those assumptions, as you said, are wrong, frankly. I think there are issues in terms of whether this is obviously going to change trend. Some contracts might have risk corridors, some contracts might have stop loss provisions for individual cases, but the issue is it's going to be, if it's not something that's addressed at the regulatory level from insurance commissioners, it's going to be something that providers, ACOs, and are going to have to negotiate within the context of their contracts. And obviously that is a very complicated situation. As you said, these are heavily negotiated. I just think it's going to be a fairly unknown situation for this to be happening across the country.
I would agree with that.
So it sounds like now might be the time for providers and insurers to start taking a look at those contracts and starting to have those conversations to figure out what the contract language says and how we can negotiate these so that the contracts reflect what the reality on the ground is and will be going forward.
I agree, Steve. I think that process will start, but I suspect it's going to last much longer than this. That's going to extend even beyond the year, frankly, because a lot of these performance years will be through the end of the year. A lot of these discussions, while you can start them now, will probably not happen until reconciliations that are after the end of the year.
There'll be a lot of folks involved, lobbyists working with the insurance commissioners, the contracting folks, the data folks. There will be lots of attention and discussions between those folks who are affected by these dynamics.
Lots to stay tuned to. Well, I appreciate both of you for taking the time joining me today. And thank you again to our listeners. Appreciate you listening to this episode of Triage.
Thanks again for listening to Triage, rapid legal lessons for busy healthcare professionals. New episodes are available for download through iTunes, Google Play, and other podcast applications. By subscribing to Triage, you will receive timely notifications of each new episode. Also, if you have any topics that you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.